session. I'm sure it's going to be interesting.
Thank you. Yeah, I just asked Rolf, how can I discuss biomarker at the end of the day, where it has been discussed a whole day long across diseases. So I decided, of course, to discuss some biomarkers, but to embed it in a wrap-up talk, trying to answer the question of how can we improve what we have been seeing with immunotherapy today, using what we have in our hands and not inventing the strategies that will happen 20 years from now. So we will try to cover these questions, opening a new discussion. I'm sure you have been roughly covering all these revolutionary drugs that have reached our pipeline, more than 2,000 immunotherapy agents now in development, from cancer vaccine, T-cell therapies, oncolytic viruses, of course, to checkpoint inhibitors. These agents are, of course, for many of them in phase 1-2 trials, but many of them too have reached the very important level of being compared in the context of a randomized phase 3 trial. But in most of the diseases we have discussed today, this is the landmark synapses that we are targeting using immunotherapy today. First of all, during the priming phase, the CTLA-4 interaction between the dendritic cells or the antigen-presenting cell and the T cell, and the second synapse, which happened in the tumor, between the tumor cell and the T cells using the PD-L1 inhibitory interactions. And I think you all have presenting data with these two synapses being targeted together or alone, and you have been presenting the really very important development of these compounds, having 2 anti-CTLA-4 in late development and 5 anti-PD-1, anti-PD-L1, even 6 nowadays with the addition of squamous cell carcinoma. These compounds have been showing in early trials, and this is pembrolizumab, but you can have chosen any others, efficacy or activity across diseases. So this is the early data, phase 1 trials of pembrolizumab, really proving that there is an interest to get across diseases. However, when you use monotherapy in unselected patients, right, you will have some activity, but we have to qualify this activity as remaining very modest, very limited, right? This limited data have been probably discussed today. We again speak about monotherapy unselected patients. Probably the paradigm is melanoma, where the best results have been obtained. This is pembrolizumab, nivolumab versus chemo or versus Ipi, basically really changing completely the fate of these patients. But this is, again, the best example. I have this colleague telling in the media 2 days ago that the results of immunotherapy are spectacular. Yes, he's a melanoma specialist. They are spectacular in melanoma, but they are still not spectacular using this unselected strategy across diseases. Because if this is melanoma, you've seen the urothelial carcinoma data with pembro, slightly better than chemo, but this is not what I would call a revolution, right? And even some warning, then some patients should not receive monotherapy, nivo, or pembro frontline because it could be deleterious. So still not completely spectacular, right? Let's just have a glimpse at unselected non-small cell lung cancer, better than docetaxel, but a modest benefit. This is head and neck cancer. When you can see the nivo, you can see the pembro. We have been discussing the limitation of the pembro trial, a modest benefit. This is nivo versus everolimus in unselected renal cell carcinoma. This is gastric cancer, where nivo can be discussed. Pembrolizumab, I'm sure, will open a debate about the indication versus paclitaxel, but still, this looks like chemo as compared to chemo in the past. This is still a modest benefit, right? Of course, we have some paradigm diseases where some activities have also been shown, and I like the squamous cell carcinoma because one late company decided to target this rare disease with interesting results, right, with an anti-PD-1 agent. Of course, you probably haven't been discussing today the paradigm of Merkel cell carcinoma, a highly mutated tumor, where avelumab and pembrolizumab have been showing wonderful results and long-term control of the disease. We just discussed the fact that the other very, I would say, melanoma-like disease is probably monotherapy anti-PD-1 in mismatch repair deficient tumor. And I would like to keep in mind when we discuss afterwards biomarkers that here we deal and we discuss probably partially at least mutational burden, because the number of mutation in mismatch deficiency tumors as compared to MSS tumor is very different, right? And we speak about the accumulation of mutation. And this is the curve of Ipi-Nivo that was shown. So when I start from this, not disappointing because it's better than what we had, but still kind of modest appreciation of what we have been moving across diseases, right? The question is, how can we improve these results for a better fate and for the benefit of our patients? And there are three answers to this very simple question. First of all, and this is my main topic today, is biomarker selection. So second way to move is probably to do rational combinations, even with strategies we already have available in the clinic. And the third one, which has been discussed mainly by Tom, is I think we have to move to early disease to be able to target better any cancer type with immunotherapy. So let's discuss this biomarker selection, and I will go quite fast on the very obvious one because I know you have been discussing them today. Why do you need the biomarker? Because we've been moving in some diseases, in particular in lung cancer, melanoma, to what we call precision medicine. And we try to implement precision immunotherapy. Why? Because whatever you do in cancer treatment, you present with a certain degree of risk of harm to your patient based on toxicity. And of course, selecting the patients is allowing you not to result in undue toxicity in a certain subgroup of patients. Of course, the other answer is to try to understand that there is a financial burden, and selection will help accessibility across different cancer types, countries, nations, continents to immunotherapy. And of course, the relative benefit number to treat, we say in the evaluation of treatment, is very important for every strategy you define. The idea is, of course, to try to define this ideal population where all the patients would benefit from a strategy which would allow you to get this type of survival curves in the future. I remind you that is more or less what was observed in Hodgkin disease with anti-PD-1. But where are we with biomarkers? We are at a point where we basically use two biomarkers in daily routine. PD-L1, immunohistochemistry, as measured by immunohistochemistry, and the mutational burden, or a surrogate of the presence of a high level of mutation, for example, looking at microsatellite instability. We have been looking or evaluating some biomarkers representing surrogates of the presence of an immune response already before treatment by trying to quantify immune cell or by defining immune gene signatures. But at the time being, they haven't been validated and they are not used in the clinical routine. So basically, let's discuss PD-L1 and mutational burden. PD-L1 has been a trouble for many specialists from lung cancer to other diseases. And the first reason why it's difficult biomarker to handle, it is characteristic and nature of being a continuous variable, meaning that you have to artificially define a threshold for benefit against no benefit using a continuum biomarker. So the main question is, how would you define positivity? How do you define the cutoff or intervals, or should you define cutoff or intervals? And where do you set objectively the cutoff value in order not to prevent some patients who would have benefited from receiving the therapy? So that's really a problem that cannot be solved due to the nature of the biomarker, but presents with its own limitations. And more than that, you've been hearing how we have been struggling with PD-L1 being not only expressed on tumor cells, but on many immune cells, and the various definitions of PD-L1 positivity. The 5 main companies using or developing anti-PD-1 or anti-PD-L1, now there are many, probably 6, have been developing their own test using different antibodies, different platforms, different definitions, different scoring system, making the whole story of PD-L1 positivity quite a mess. At least starting now, we are more or less solving the problem. Our thinking we were solving the problem trying to homogenize a stratified use of tumor cell staining using one of this antibody. But it's very important to state that the whole story is open again based on urothelial cancer, gastric cancer, and small cell lung cancer, with at the time being switching from tumor cell staining to a certain immune cell staining, or even the CPS, the combined prognostic score, which is any kind of staining in the tumor. So the whole story is not over in terms of PD-L1. What can be a little bit reassuring is that when you look at the various tests which have been developed with different antibodies, different platforms by many companies, they look like performing more or less the same. Maybe apart from one, which is that the staining from Genentech, the SP142, which underperforms a little bit on the tumor cell side. But anyway, what I want to say is you might use one against the other one instead of the other one, as long as you do an EQA validated process and you know how to measure it. So as long as you use the kits, a commercial test, you pick one and you validate the way you measure PD-L1, it looks like I would say, what commercial tests you choose not being so important in your measurements. However, once you move to lab-developed tests, what we like because it's cheaper, then the discordance between two institutions or even between two investigators, pathologists, will be very high. So you have to be very careful handling that. But basically, you can use one test for the other one. But still, this is the very nice Hock curve for non-small cell lung cancer. So you have this shoulder, nice one, at 50% of PD-L1, which really creates a threshold for monotherapy. It was pembrolizumab here. This is the same curve for melanoma. Okay, so here you have a problem because the ROC curve suggests that your PD-L1 or the performance of PD-L1 will not allow you to guide your treatment selection or treatment decision process across tumors, maybe in lung, but not in many others, right? PD-L1, again, like we said, does not allow for your binary classification you'd like to have because it is continuous variable, but also, like Tom said, it's a heterogeneous but a dynamic biomarker. Probably if you measure it in an archival sample, it might not reflect what is the current status of the tumor. And of course, what we don't like here is a poor negative predictive value. Some negative patients still benefit sometimes from checkpoints. But based on that, and the ROC curves on non-small cell lung cancer, this is an example of an improvement of the unselected strategy by looking at high PD-L1, the shoulder, 50%. This is pembro monotherapy versus platinum-based chemo frontline, and you can see how stringent you can be in really improving the fate of your patient doing that. This is melanoma. In melanoma, you had the Ipi-Nivo, Nivo-Ipi. Ipi-Nivo is in orange, and Nivo is in blue, and Ipi is here in green. So no real difference between Nivo-Ipi and Nivo, but it looked like in this trial that if you really focus on the patient with no PD-L1, it might be, but still it's a kind of an abusive comparison, but it might be that Nivo-Ipi is a little bit more indicated when the tumor doesn't show a signal for pre-existing immune response. So basically here, maybe PD-L1 can have a value for this very specific question. But let's look at renal cell carcinoma. Renal cell carcinoma, I've shown you the Nivo versus everolimus. PD-L1 doesn't change anything. So it's about the predictive value of PD-L1. Other biomarkers. The TIL story is an old story. In melanoma, where they always have a very nice piece of tumor or metastasis or in-transit tumors, they were able to show how any kind of response to immune checkpoints would be related to the presence of pre-existing TILs. And these TILs can be nicely distributed in the tumor. It will be the ideal scenario, but sometimes they just sit at the margin of the tumor, but still, if you have TILs, you don't have this, what we call the immune desert. If you are outside of this scenario, you will observe a TILs-related and dedicated response. In all of the tumors we have been studying, TILs are the positive prognostic factor in terms of post-surgical setting, for example, but in most of the trials where you have enough samples, also predicting activity of checkpoint in advanced disease. But for example, in lung cancer, we almost don't have any strong data about it because of the unavailability of good tissue samples for this type of measure in advanced disease. The last but not least biomarkers that we need to discuss thoroughly is the mutational burden. And you know these papers, there are 3 exactly reproducing this data today, trying to count the mutations you find in various cancer types. the mutational burden. The idea is simply that it's a probabilistic approach. The more mutation, the higher the probability some of this mutation will generate good neoantigens to be seen by the immune system. So it's a probabilistic approach, purely, right? It's a surrogate of a surrogate. In lung cancer, we like it because mutations can also define a certain category of patients because of the smoking signature. High mutations define nicely this poor population of smokers who would potentially benefit more from immunotherapy, more neoantigen. But again, I told you it's a surrogate of a surrogate. Having a high number of mutations does not mean that you will have good neoantigen. When you have a mutation, first of all, it doesn't mean that your mutation will be transcribed. So it doesn't mean it will result in a change of the protein in the cell. So second thing, if it would be the case, it doesn't mean that the folding of the protein will expose this change to any kind of presentation to the immune system. Would it be the case, it doesn't mean that the restriction you have in the way you can present to your T-cell and immune system based on your MHC restriction would fit the specific mutation which was expressed. Would it be the case, do you have in your repertoire a single T-cell being able to recognize, pre-existing of course, being able to recognize a specific mutation? So it's really a short way. Mutation doesn't mean neoantigen, but still, in a probabilistic manner, we try to anticipate that if you have a lot of mutations, you might have a good neoantigen. But still, when you count the mutations, some highly mutated tumors, you can see it's lung cancer, it's a paper of Nayer Rizvi. Some patients have a very high number of mutations, but still no benefit of pembrolizumab. You can see this patient in red here. Okay? So this is the proof that the number of mutations is not enough. And you can see here also, when you look again at this curve, this is the response rate to monotherapy, immunotherapy. Unfortunately, this is not a proportional change in the response rate, meaning that counting the mutation is probably not enough. This can be partially explained, and this is a simplification of the explanation, right, by what we discussed before regarding BRCA and PARP inhibitors, that what defines the potential existence of a T-cell clone responding to a mutation is the clonality of this mutation. So mutation has to be a founder, a pre-existing mutation found in all the cancer cells of your tumor to have a certain clonal expansion of a specific T-cell response. And this was nicely described in the Nayer paper and can be described by the heterogeneity of the presence of the mutation. So basically, when you remember the Swanton story of the tree and the branches, your mutation has to be really in the trunk of the tree and not in the branches to be able to result in a neoantigen presentation and T-cell response. But with all the limitation I have told you, okay, mutational burden is a very good predictor of immune response. And here you can see data in melanoma with anti-PD-1, anti-CTLA-4, in non-small cell lung cancer, in small cell lung cancer, in colorectal cancer, and so on and so forth. And I would even exaggerate telling that it's fairly more robust than PD-L1 in terms of being transversally predictive of the response to immunotherapy. All these data I have shown here are not feasible on a daily routine, are not to be obtained on a daily practice because they have been obtained by whole exome sequencing, which costs a lot of money and takes 8 to 12 weeks to get the results. So it's not something you will use frontline in small cell lung cancer. But what was nicely shown too is that you can correlate the whole exome sequencing to the usual large panel we have been using. This is the Sloan Kettering Impact panel. This is the Foundation Medicine panel, and the correlation is very nice. So provided you use a large panel, not the small one you use just for EGFR mutation, but the large one which is more or less 300 or 400 genes, 1 point something megabase, you can surrogate the whole exome sequencing. And this is a nice editorial in the New England correlating the number of mutations by foundation panel with the response rate to immunotherapy, monotherapy. So showing you that here you have a good correlation. Okay, but in lung cancer, for example, my pathologist, I'm fighting with him quite a lot these days, is telling me that, okay, you ask me for telling you it's a lung cancer, telling you the histological subtype, telling you if there is an ALK translocation by immunohistochemistry, telling you if there is an EGFR mutation, a HER2, a BRAF, a PI3 kinase, and so on and so forth. And sometimes even some strange questions. And at the end of that, you ask me, can you just let me know about the TMB? So the problem is that we have some limitations in assessing TMB because you don't have DNA anymore, right? And practically in lung cancer, to date, in clinical trials, only half of the patients have enough material to get TMB. So we have to change probably the way we behave in all doing like that in the way if we want to obtain TMB. The other question, and we're trying to publish a paper about it, but it's a nightmare, is how are we going to homogenize, to harmonize the TMB measurement and description in the future? The first answer is it's way simpler than PD-L1. And it's not a big deal, right? We have to, we count mutations. I mean, this is not a big deal. But we have different platforms, and we have different ways to describe the mutations. Mutations can be silent, not silent, can be frame-shift, can be indels, can be single nucleotides. So we need to harmonize the way we describe. And there are two efforts, one from the US and one from the German group, trying with an objective at the end of the year to help you using your own platform. Would you be equipped with Illumina, with Ion Torrent, or whichever, to be able to use your platform to define a TMB using a simple informatic system which will help you to get there? And I'm convinced it's going to be the case. So you understood that I'm quite convinced about the TMB in the daily practice. What is very interesting is that TMB is independent of PD-L1. So you have two biomarkers defining potential prediction of immune response, and maybe even additive. This is the data I presented at the AACR already 2 years ago, showing you that when you are double positive, it might be that you are the best patient population for nivolumab. It was nivolumab Frontline trial. Next step for TMB. TMB might potentially be measured in the blood. This is the effort of Genentech and Roche in lung cancer, trying to define on the circulating DNA using a little bit larger footprint of 1.4 megabase, trying to define TMB in the blood as a predictive biomarker. There was a testing and a validation cohort in the phase 3 trial, the OAK trial, and you can see here that a high TMB allows you to predict the benefit, a higher benefit of immunotherapy as compared to chemo that you will not find in low TMB. It's interesting, high TMB here is defined in 1 patient out of 4, and again, it's completely independent on PD-L1. But of course, it's retrospective subgroup analysis, so it means that you might just be looking at artificial data. They just perform a very debatable phase 2 trial where atezolizumab is given, but patients are assessed for TMB. And you can see that it's just a prospective cohort, that high TMB patients respond way better than low TMB patients. This is a different PFS curves. So of course, still some discussion because there's not prospective implementation, but there's really something here to think for the future in the blood. It's a matter of debate and the community, and we try to reproduce it in the Ludwig Institute, and this was unfortunately not as successful today. So this is really something that has, we'll bring that in our hands probably in the future. What the problem we have with circulating DNA in general? So first of all, is not all the tumor do a similar shedding of circulating DNA. So lung will not be the same as glioblastoma, of course, but will not be the same as compared to prostate. The other thing is the tumor stage. The tumor burden, the tumor load will change the amount, we modify the amount of DNA shedding in the blood. And the last thing is the location of metastasis might also change this parameter. So it's a bit less straightforward to look in the blood as compared to a tumor sample. Other biomarkers for tomorrow, very rapidly, we had this very interesting data about the fact that, and you cannot modify it, we are not all equal in front of the antigens that are presented to our immune system, and in terms of how diverse they can be, and we can recognize them based on our HLA composure. So we are not all equipped the same way, and the more heterozygous you are with your HLA class 1 genetic background, the more you are prone to respond to many different types of immune stimulations, including the context of cancer antigen. And last but not least, we discussed it, and it's also a real matter of debate, the microbiome, which looks like being a strong biomarker for response to immunotherapy, with some bacteria have been associated with a very a positive impact on the response to immune checkpoints, and some bacteria on the other way being associated with a no response or a negative impact in terms of immune benefit from checkpoints. But importantly, if you try to summarize that, what was shown to be important is fecal diversity in terms of flora in the gut. So the more diverse you have, the more different bacteria you have, the more prone you are to respond to immunotherapy. And of course, the other way around is very simple. If you expose your patient to many rounds of antibiotics, you probably lower his chances to survive longer with immunotherapy as compared to the other one. This is a matter of debate. We can discuss it later on. Why? Because of the potential description of different patient population when you look at their microbiome. It might be you don't describe the same patients. But basically, the experiments with fecal transplant in the mice tend to show that really there is something influencing the immune response, and by giving the flora of a mouse to another one, you might change the way the mice will respond to immunotherapy, and this is ongoing in human, at least in some centers in the world. The problem will be that by developing all these biomarkers, you will not have one biomarker, but a signature of biomarkers to be used to predict who are the patients you'd like to treat with immunotherapy. At the time being, we are moving with mutational burden and PD-L1, at least in lung cancer, but you have this development of the series of biomarkers which will force us to develop a certain signature with some of these biomarkers in the future. And please keep in mind that imagine just that you are going to use TMB, PD-L1, and TILs, which looks like very obvious. Maybe you will have sorted out the difficulty to define cutoffs and their interdependence, because they have to be interdependent. And maybe you will decide to add some of the other biomarkers that I have been quoting. And if you decide at the end to move with 7 parameters, that you will define 128 subgroups of patients to know if you have to give immunotherapy or not. So you have many biomarkers, but you will have to decide which ones to use in your future signature. So biomarkers, we've gone around. Second, very fast answer, how can we improve immunotherapy results? The rational combination. So we have been moving across diseases with many combinations. We are not very inventive, because all of these combinations use a backbone today of PD-1 or PD-1 blockers. And we add on the top of them. We add some other immunotherapeutic agents, we add chemo, radiotherapy, we add vaccines, and we add some other strategies. But this backbone is a very strict, I would say, parameter in most of our combinations. The idea, for example, of combining checkpoints with chemotherapy is the idea of this immunogenic cell death you have been discussing. Dying under a certain strategy, for example, some chemotherapeutic agents, is not always equal in the way it will promote an immune response. And some drugs are very prone in having this immunogenic cell death, resulting in a very efficient presentation to the immune system. The other thing is the combination with anti-angiogenic drugs. This is a literature from the 90s, that VEGF is a very important regulator of the immune response, and that anti-angiogenic drug might be a very good promoter of a stronger T-cell trafficking, presentation by dendritic cell, and T-cell activation. So we have been moving a lot in diseases with chemo, targeting the immunogenic cell death, radiotherapy, targeting some alert signal in the same way of immunogenic cell death, and anti-angiogenic drugs. Many examples in lung cancer. I cannot show all of them to you, but this is the usual frontline chemotherapy, platinum pemetrexed, and you add on the top pembrolizumab, and you can see the difference. I just would like you to keep in mind that to me this is everything except personalized oncology or precision oncology, because again, you go back to giving the same thing to all of your patients. So I think we can potentially refine the strategy, but it is a new standard of care. If I say refine, the strategy is still, if you look in this trial at the PD-L1 negative patients, right, this is the PFS curve. I'm still not convinced that it is spectacular. So I'm still not convinced that this is really a strategy for all comers patients frontline. So we will have to dissect all this in the future. But basically, this is a very positive trial. The other strategy I would prefer in terms of what the patient would choose and trying to get long-term control of the disease is potentially to spare chemotherapy for the next lines and only use immunotherapy. And this is the nivo-EP versus chemo frontline in patients with high TMB. High TMB was defined here by more than 10 mutations per megabase using Foundation Medicine panel. This is a definition which is quite valid across diseases, by the way. But again, not all are evaluable, but this is really a very strong benefit of nivo-EP versus chemo in these patients who represent half of our patients, right? And in this patient population, what I like is it becomes completely independent on PD-L1. So here you suddenly have a subgroup of patients with no negative selection to be used afterwards. But of course, this is the landscape of lung cancer. To make a long story short, you have here the PFS and the survival with the standard of care and the combination with checkpoints across many trials in squamous and in non-squamous. You should never do that because we compare trials and trials, but the only three conclusions I'd like you to have are the following. First of all, we have been defining many new strategies in squamous and non-squamous which are better than platinum-based chemo. Combining with checkpoints is better than platinum-based chemo. So if you can, when it's going to be reimbursed, you have to do so, okay? Second thing is we will refine the subgroups of patients who really benefit from adding a checkpoint. And you can see here that, for example, this is a subgroup of PD-L1 negative, but there might be some subgroups of patients where you would potentially favor nivo-EP or you would potentially favor chemo and checkpoints. But still, we don't know. We are going to define it in the future. Last but not least, the toxicity profile and the patient preference will be very important to us. And having had the opportunity to date to use all these combos more or less in Switzerland, in my center, when you tell a patient with a high TMB that he can receive only immunotherapy with 30% of grade 3 to 4, as compared to giving chemo plus a checkpoint with 70% grade 3 to 4 toxicity, usually the patients prefer not to get chemo and keep chemo for later time point, but also having a lower level of grade 3 and 4 toxicity. So this is a discussion you have to have with your patient because you don't know what is better. I don't know, but this is what I can offer to you. Frontline strategy combinations, improving what we have been showing not being spectacular, is also valid in renal cell carcinoma. Nivo-EP is better than sunitinib. We discussed it. EMA refused it, rejected it. But also we have the atezo-bev, which is also better than sunitinib in PD-1 positive patients, which might also define a strategy that I can imagine. I'm not a renal cell carcinoma doctor, but is better tolerated than sunitinib generally in terms of tolerability. And melanoma, we discussed it with the EP-nivo being a strategy to be performed in selected patients. This is a revolution, right? This is what has been shown as being high level of evidence, or because of grade 1A level of evidence, but also because of rare entities that has been defined frontline combinations mainly, or second-line monotherapy as being high magnitude of benefits and level 1A evidence-based medicine. So we have changed completely the way we treat patients. You know that there are many trials to come at the World Lung and ESMO meeting, lung cancer, breast cancer, and head and neck cancer. All the press releases, that's a new fashion, have been showing that. Many combinations are likely to fail. That's the landscape of combinations published by Ira Mellman in the past. We have been showing the dramatic failure of IDO inhibitors despite the wonderful phase 1-2 trial. Same thing with cobimetinib atezolizumab, very promising early trial, very disappointing overall survival, late data. So many of these combinations might fail, and I think we need a stronger rationale to move to combination. In the last 3 minutes, what do we think about early disease and why do we think about early disease? Probably a patient with an early disease has a more conserved immune system and probably also a better capability to tolerate the drugs and mount an immune response. This is neoadjuvant nivolumab in Merkel cell carcinoma. You can see here a 40% response rate, lots of complete response after 2 cycles of nivolumab, only 2 cycles, sorry. This is a 2 cycle of nivolumab before surgery in non-small cell lung cancer. 45 of the patients had less than 10% viable cell as described by major pathological response. This is the consolidation durvalumab in stage 3. after radiochemo, with a very strong benefit in overall survival, as announced by press release, will be presented in 3 weeks. Neoadjuvant immunotherapy in melanoma, 1 dose of pembrolizumab, and you can see here almost 30% of the patients in near complete response. This really defines a new strategy. And of course, the competitive landscape of adjuvant trials in melanoma, where after surgery, giving EP, giving Nivo, or giving pembrolizumab will cure, probably cure, because we need some longer follow-up, but probably cure more patients from melanoma. So it's a very specific topic here, which is about moving immunotherapy to early disease, which will dramatically improve the fate of the patient. And with this, I thank you for your attention.
I don't see so thank you very much for your talk.